Assalamu alaikum and welcome you all. At first, I would like to thank the TMSS Medical College for arranging such a good session and thank Dr. Shaikh Ahmed Rinko for inviting me here. And I'm very much delighted to be here in Bogura, the land of the archaeological heritage. Here, basically lots of friends, seniors, juniors, and my medical colleagues, my medical roommate also live here. So Bogura is very much like my second home. So I have no conflict of interest. I'm working in Dhaka Dental College and Hospital. It is 200-bed hospital. Basically, 50% of patients are admitted with oral cancer. And today my topics is about comprehensive management of advanced oral cancer. And you see the previous slide, the Globocon report. Oral cancer is the now second most common, and in mortality, oral cancer in Bangladesh is the second most common cause of mortality due to cancer. Each and every day we face this type of advanced cancer, and this is due to the delay of the treatment. The delay ranges from the 27 days to the 360 days, and the mean delay is about 78 days. And a few studies showed that is advanced oral cancer management in case of T4A and T4B a little bit similar when they go for the treatment. And we have studied 200 cases from 2012 to 2023. Each patient studied at least 5 years. And I'm seeing my result. Here, male is predominant. And according to the side cheek, lower GBS, upper GBS, RMT, and these are the most common. And in staging, the T4 A is the most common in my study, and all of patient took adjuvant radiotherapy, and only the 11% they could not, and every patient took the radiotherapy, and 24% they took concurrent chemoradiation. And my overall survival is 68% 5-year survival, and disease-free survival is 64% 5-year survival. And according to the stage 3, 4, they shows the overall survival is no significant difference. And stage 3, 4, all are disease-free survival are a little bit similar. And in my reconstructive procedure, I use in case of mucosal and skin defect, you use the radial forearm free flap or chimeric ALT. Mucosal and bony defects, we use the ALT with recon plate or free fibula free flap with skin paddle. And in case of mucosal, bony and skin defect, we use the chimeric ALT with recon plate and free fibula flap with the chimeric skin paddle. And central part of the mandible defect, we use the fibula. In case of tongue defect, as tongue needs some mobility, we use the radial forearm free flap. But in case of near total glossectomy, we use the anterolateral thigh flap. And upper gingival sulcus defect, we use radial forearm free flap and ALT also. And lip defect, we use the radial forearm free flap. So here the lesion in the cheek and involve the commissure and skin. We excise the lesion with marginal mandibulectomy, and reconstruction was done by radial forearm free flap. And this is the ultimate aesthetic and functional result. And patient is going 7 years. This is tongue, midline is close to the tongue, depth of invasion is more than 10 millimeter. And radial forearm free flap is best for the hemiglossectomy defect. Here is the defect and reconstruction. And here is the video for tongue movement. And in case of central part of the mandible, floor of the mouth lesion, it is excised in compartmental resection. Sorry. With suprahyoid muscle, floor of the mouth cancer is excised and reconstruction done by the fibula. But in case of large lesion, In case of large lesion, we choose the anterolateral thigh flap because it gives us more and more tissue. Here the exercise mass, and this is after reconstruction, and this is T4B lesion, that is ITF involvement. Patient has trismus and infratemporal fossa compartment, that is masticator space is involved. Compartmental resection was done, and it was reconstructed by the anterolateral thigh flap. And this is 5 years later. This is also a masticator space involvement. Here you can see the restricted mouth opening, and ITF is involved, and compartmental resection of the done, and that is reconstructed by the anterolateral thigh flap. Chimeric flap was done, and that is after reconstruction, and this is 4 years is running. So oral cancer is a major problem with large burden of advanced cases. Compartmental resection have promising result, and salvage for the advanced diseases has satisfactory outcome. And thank you so much.
Thank you, sir, for your nice presentation. Any question?
Thank you, Dr. Abdullah Masood.
Thank you, sir.
Dr. Abdullah Masood is a good surgeon, and in maxillary surgery, he's almost leading our precise surgical procedures.
Thank you, sir.
And now, one thing is about T4 cancers, and also two slides you have shown tongue cancer about crossing the midline. In that cases, what is about post-operative margin clearance?
First of all, in case of near midline, you have to go beyond the midline. In resection, there is extended hemiglossectomy, and then you send the histopathology for the frozen section. According to the frozen section result, you go for the reconstructive procedure.
Are there any post-operative radiotherapy or chemotherapy?
In case of all advanced diseases, according to the lymph node status.
But the one thing is now oncologists, if there is margin, all margins are clear, no margin, no lymph node involvement, then they don't want to go for radiotherapy or chemotherapy.
But in case of advanced diseases, I can say, in case of advanced diseases, when T is T4, so only single modality treatment is not the enough. We can excise, but there are some micro tissue may remain. So in case of T1 or T2, you can go the single modality treatment. But in case of T3 or T4 lesion, you cannot go to the single modality.
Okay, for your attention, sir.
With radiation, if we apply chemotherapy, that is concurrent chemoradiation, it acts, this chemotherapy acts as a radiosensitizer. So effectiveness of radiation will increase. This is why we use chemo radiation.
One thing is about even T1 and T2 cases, if there is another thing is worst pattern of invasion. If the invasion is within 4 or 5, then radiotherapy or chemotherapy is essential. But oncologists in our country, usually, they, in case of T1 and T2, they don't want to go for radiotherapy and chemotherapy in that cases. But in other countries, I think in India also, they think about worst pattern of invasion.
Invasion is one of the factor, but tumor size, tumor margin, all information actually not optimum in our histopathological report. This is one of the important issue because if I share my experience in stage 1 or 2, if we kept in follow-up, then it is usually come back with recurrence within
1 or 2 years. It may
this is why we are usually we apply radiation in early stage also.
Thank you, sir.
Thank you, sir.